Good afternoon and welcome to Intermountain Medical Center TV, a health information program originating at Intermountain Medical Center in Murray, Utah. My name is Bryant Larson and I'll be your host today. Our topic is stroke and I'm joined by Dr. Chloe Wan, a neurologist here at the Medical Center. Welcome, Dr. Wan.
Thank you very much.
Appreciate your being with us.
Happy to be here.
Why don't we start out with having you explain just what happens when a person has a stroke? I often hear the phrase, it's a brain attack. Tell us what exactly happens to the body when a stroke occurs.
Okay, so a stroke is a vascular event that happens in the brain. So that is any kind of blood vessel problem, either a blood clot, so a blood vessel being blocked, or a blood vessel being injured and busted and causing bleeding in the brain. So there are different kinds of strokes. The most common form of stroke is a blood clot that happens in the brain, and that accounts for about 80+%. And then the rest of the strokes are what happens when there is a blood vessel injury causing bleeding, which can be a specific blood vessel at a specific point in the brain, or it could be more diffuse, and there are various terminologies that we won't get into that would define how these are treated and what are the other implications and treatments for the bleeding kind of strokes.
Oh, okay. So the blood clot then is the much more common of
Absolutely. The blood clot type of stroke is much more common, again, accounting for over 80% of the strokes that we see.
Oh, okay. We often hear the term TIA. Can you explain what that is and how that relates to a stroke?
So the TIA stands for Transient Ischemic Attack. Basically, it's defined as a transient, a stroke, also a vascular event, so a blood vessel disease of the brain that's called, that is not as long-lasting as a stroke. Traditionally, it's defined for less than 24 hours, and it can very much vary in terms of lasting 20 minutes versus lasting, let's say, 20 hours. I think with the advent of more sophisticated imaging, such as MRI scan, we're basically able to pick up a lot more TIAs being more defined as stroke because they show up on the MRI. So TIA can either show up or not show up on the MRI, but basically you can think of it as a light or a brief stroke that has resolved completely after about 24 hours. Okay. Sometimes TIA in the lay population, also in medical community, can be somewhat loosely defined, and a lot of things are referred to as TIA. And I want to sort of specify that in the traditional classical sense of TIA, this is just like a stroke, that it is a vascular event, so a blood vessel problem, as opposed to things that can mimic strokes, such as seizures or metabolic changes or medication side effect, migraines, and things like that.
Okay. What are the symptoms of a stroke? I get the sense a lot of people are confused, wondering, is this really a stroke that my partner's having, or is this just a headache? Or
Absolutely, that's a great question. So sometimes it's very difficult to tell, but the most classic symptom of the strokes are usually one-sided, and so the National Stroke Institute has give us this mnemonic called FAST, which stands for face, so facial drooping, which usually is one-sided, and the A stands for arm, so arm weakness, and if you hold your arms up and one side is not working or is weaker than the other, and the S stands for speech, either slurred speech or inability finding words, or talking in gibberish does not make sense. So it can be slurred, or this difficulty coming up with language. And time is not a symptom, but it says the T stands for time, which is time to call 911 and get some help. There are lots of other symptoms that can happen with stroke, and it becomes somewhat sophisticated in terms of figuring out whether it truly is a stroke or one of the stroke mimickers. But I think in the sense that there is an abrupt neurological change that is persistent as different from your baseline function, especially when it's one-sided or involving speech. I think their suspicion for stroke is very high, and you should seek care immediately.
Okay. So that FAST acronym would be important for
Absolutely,
the layperson
and
to
that's a
keep in
very
mind.
fairly easy acronym to remember.
Okay, so T is for time. One of my colleagues tells me there's information on the internet right now that T stands for tongue, and there's some kind of odd test to stick out your tongue. So it's good to know that's not what that stands for.
Right. So, tongue being towards one side or another certainly can be a sign of stroke, but independent of everything else, that would be pretty unlikely with the tongue being the only thing involved to be a stroke.
Great. I'd like to remind our audience that we are taking calls today. If you'd like to call 801-507-2807, we'd be happy to have Dr. Wan respond to your calls. You're also able to post a question on Facebook, and it looks like we have our first post from Leslie. She's asking Dr. Wan, how do you tell the difference between a migraine and a stroke? Great question.
Absolutely. Hi, Leslie. Thank you for asking this question. And this is actually something that we deal with on a daily basis, treating acute stroke and trying to triage and provide the most appropriate treatment for either the migraine or the stroke. I think sometimes it is pretty hard to tell the difference. In some sense, you can think of it from or a demographics kind of way. Migraine patients usually are younger and stroke patients usually are older. This definitely is not an absolute. We certainly see younger patients with stroke and older patients with migraine. That is the general rule, and also migraine patients usually have a history of migraines, and often there is accompanying headache with the neurological symptoms. And also they're usually a bit more vague in the sense that it's not I can absolutely not lift my arm up or the face is completely drooping on one side, although even that is possible in the migraine and in certain types of migraines especially. One of the common things that people say about migraines when they have a lot of sensory changes is that it's a marching type of sensory change where, let's say, it starts on the face and over course of a minute or a few minutes marches and progresses into an arm, for example, as opposed to a stroke. Often you get the face and arms all affected at the same time. Again, these things are not absolute, and often if this is your first episode or if this is a very unusual episode, our recommendation is to seek help and for us to come and determine this as opposed to assume that it is a migraine and for this to turn out to be a stroke that may recur and especially without treatment. So certainly a difficult question to answer, and sometimes it's even after a lot of workup we still can't tell definitively, but these are some of the clues that can help you try to differentiate that, and of course ask your medical provider in terms of the best way of telling if you have had several episodes of migraine related neurological deficits.
So if a person, let me follow up, if a person suspects it may be a stroke, you'd encourage them to seek care. Is that the emergency room in most cases? Yes,
with a suspected acute stroke, the best thing to do is act fast. That's the other part of FAST being a great acronym, because the mantra for stroke care is time is brain. The quicker we can get the clot resolved or get the bleeding stopped, the more likely you'll have a better outcome from the stroke. So the idea is to call 911 right away and try to get into an emergency room that is able to handle stroke and potentially give an acute treatment for clot busting medication if it is the clotting type of stroke within the time window. And I think that leads us to the next question of, some people probably have heard that this medication that's called TPA, which works by dissolving a clot or helping to dissolve a clot that may form in the brain causing the stroke. And the clotting type being most common, this is one of the most common triage questions that we have, whether the patient is appropriate for this medication. What happens is usually I come to the emergency room and we do a quick CT scan to make sure this is a clotting type as opposed to bleeding type, because they are treated fundamentally so differently. And after that, with a neurologist or an ER physician evaluating whether it's appropriate to give this clot busting medication. The time frame for the clot busting medication, It depends on the situation. The traditional time frame is 3 hours. That has been extended in some population to 4.5 hours, and in certain cases, even 6 or perhaps more in special circumstances, with more than just the IV intervention right away. However, even though we have this time, we know that the quicker you can get it, the better. And even let's say you have 3 hours, we don't recommend you wait 3 hours to come in to catch the deadline there.
Speaking of that timing issue, there's been a lot of press recently that Utah has been singled out as really leading the nation with I guess they call it door-to-needle time, the amount of time it takes to get TPA into a patient. Intermountain Medical Center is certainly a leader in treating stroke patients. I think we see more than any other hospital. What has made us so good at a quick turnaround time and getting people the medication when it's appropriate?
Right. So I think the availability or the ability of patients getting TPA is very time dependent, and there are two factors. Both one is on the patient side of recognizing the symptoms and getting help, and that's part of the time dependence. And the other part is the medical community, once the patient seeks help, to be able to give this medication and finish the evaluation quickly. I think we have a very good protocol in terms of doing this. We just got some data to say that national average of door to needle time within 60 minutes. So you arriving to the emergency room to us giving the medication for nationwide is about 40-some%. I think for Utah is 60-some%, and for our facility here at IMC, being a primary stroke center, is 85%. And I think that's pretty impressive, given all the complications sometimes in determining why this medication is or is not appropriate. I think part of that is the fact that we have in-house neurologists who are able to evaluate this immediately, and we have these protocols set in place where the patient comes and immediately they get a CT scan without waiting for neurologists to respond, getting all their labs evaluated quickly, and the pharmacist being there quickly. And I think it's a procedural and protocolized way of getting this as quickly as we can.
So a real team approach, it sounds like.
Absolutely.
To getting all the specialists involved with the care as quickly. You mentioned earlier the question about migraines and talking about the fact that typically stroke is seen in an older population, migraines younger. That said, I've met a number of our stroke patients in recent months and was surprised. A couple of young men, very healthy young men in their 30s, a couple of women in their 40s. Are we starting to see stroke early and earlier, or is it that we're just detecting it better, or what's your sense?
I think we are seeing a lot of stroke patients pretty early. I think some of it is certainly anecdotal, or the fact that we're detecting them better and people are more aware and seeking help faster. I think the other possibility is that there's certainly this rising epidemic of obesity and all the cardiovascular complications that is associated with this. I think partially based on this, we're seeing younger patients who also have diabetes, have high blood pressure, have vascular disease that put them at risk for having strokes.
That leads us to the next question, obvious. What are the risk factors that might lead to stroke?
Sure. So risk factors, I think we know the common ones pretty well. High blood pressure is the #1 risk factor, the highest risk factor for stroke. And that's something we can do something about. Other risk factors such as high cholesterol, diabetes, atrial fibrillation, which is this abnormal heart rhythm that can cause stroke as well. And multiple other things, including genetic risk factors, age, and so forth. Certain things we're born with the genes that we have. We're born with, the age is not something we can change. But I think given stroke is one of the leading causes of death and the leading cause of disability, if we can change the things that are within our control, including our lifestyle, our diet, having our blood pressure, other cardiovascular risk factors under the best control, I think that is the best way of preventing stroke, both the first-time stroke as well as recurrent stroke.
It absolutely makes sense. Amazing how some of those same prevention things
Absolutely.
seem to pop up in so many different disease types. My understanding Intermountain Medical Center has been involved with a campaign in the past few weeks promoting how salt can lead to high blood pressure and therefore stroke. A little character named Dash that's been appearing all over the city. Talk to us a little bit about salt specifically. There's been a lot in the news lately.
Right.
Why is that a risk factor, and how can we reduce the amount of salt in our diets?
Right.
I think there's a lot of people that don't use the salt shaker routinely, but still are getting a lot of sodium.
Right. So I think there's some studies to say Americans get about 3,500 milligrams of salt a day, and the recommended salt intake is about 1,500 milligrams.
Wow.
So less than half of what we routinely get. And there are certainly people who, before even tasting the food, they're using the salt. They're putting the salt on, sprinkling on the food. That's something that's easy to cut off. Our taste for salt is something that's changeable. So the more that you're used to having saltier food, the more you need that saltier food. And once you start backing off, the less and less you're able to, you don't notice the difference as much. The reason salt is so prevalent is because it makes food taste better. And it's a fairly cheap thing to add in without a lot of other spices that perhaps is more expensive or harder to preserve and so forth. So there is actually a lot of salt in a lot of processed food, and even if they don't taste salty per se, there's actually a lot of salt as a flavor enhancer or as a preservative and so forth. One of the ways we can be aware of our salt intake, in addition to just not adding extra salt when we cook or when we're eating, is to decrease how much processed food we eat. And when we do eat processed food, be aware of the labels on that. And on the nutritional label, there usually is the sodium content on every food. And obviously the portion size also makes a difference. So you are able to track this to some degree and see, if extra salt intake may be causing blood pressure problems. And then speaking of blood pressure, we know that the goal set by national organizations is that 120/80 is the ideal blood pressure. So under 120/80. 140/90 is official definition of high blood pressure, but that in-between range still counts at some, it still increases your risk. So that 120 to 140 is still a bit of a problem. Obviously, the higher the worse, but with being that pre-diabetes, pre-hypertension stage still gives you extra cardiovascular risk factors, including for stroke.
How often would you recommend people have their blood pressure checked?
I think it depends on whether you have a history of high blood pressure or not. It's easy to get the automatic cuffs at drugstores or even buy a blood pressure cuff if there is a family history of blood pressure, or if you do have overweight or obesity as a potential problem or have a history of blood pressure, then we don't need to be obsessive to do it every day, but I think it sort of depends on the recommendation of your doctors and also, what your pattern had been in the past.
You mentioned atrial fib as a condition. There's been a lot of discussion about PFO closures, is that what they're called, in terms of treating that?
Right.
So could you speak to that and how that may or may not affect risk for stroke?
Absolutely. So PFO stands for patent foramen ovale, which is a congenital heart abnormality in some sense, because the way we shunt blood as a fetus in the womb is there is this hole to allow blood to pass from one chamber of the heart to the other. For the majority of adults, that closes once we come and breathe air, and so that is no longer in existence. But about a quarter of the population actually still has a little remnant of this hole, either from a very small amount or a pretty big hole. And this allows potentially a clot from the venous system, so rest of the body, to filter through this hole and directly go to the arteries, which can then let's say, go into the brain or other parts of the body and cause a stroke, a blood clot. So given that this is so prevalent in about a quarter of the population, and we certainly don't see strokes in a quarter of the population, there's a lot of debate to say exactly how much stroke is caused by PFO. And I think in patients who have what's called cryptogenic stroke, so stroke not caused by anything else that we can define, PFO actually accounts for a fairly decent number, not quite half, about a third to a half, something along those lines, especially in younger patients who have no other clear reason to have a stroke. And so in those kind of situations, there actually are quite a few studies coming out to try to debate whether it's appropriate to close them or not. And I think the jury is still out, actually. So we are not quite sure what the best management process is. And IMC is actually involved in an active study trying to figure this out. So I think it's an individualized approach to see how big the hole is, what the other possible causes of strokes are, but I don't recommend people just to have their closed without any indication of stroke.
Sure. Okay, well, thank you. You have the privilege of treating a lot of stroke patients while they're here at the hospital. What could you describe for us, besides the TPA administration when they come into the ED, what kinds of things might happen to a patient as they're being treated for stroke? And I'm sure that varies depending on how severe their symptoms are, but could you describe that a little bit for folks?
Right, so not everybody qualifies for TPA depending on the window or depending on the severity of the stroke. So first of all, TPA does have some risk as well. That's why we want to be sure that you're having a stroke and this is going to help before we give it to you. And the risk mainly is bleeding, including in the head, which can be pretty serious. So once you do have TPA, you're monitored in the ICU and make sure that there is no bleeding complications and so forth. If you do not qualify for TPA, that does not mean that there are no treatments for the stroke. So blood pressure management in a stroke situation is important. We actually let the blood pressure run high, so there's more blood going to the head, assuming it's a blood clot type of stroke. Also, other blood thinners, including aspirin or other antiplatelet therapies, include Plavix, Agronox, some of the other medications I think are appropriate in the acute phase of treatment. And one of the main reasons to be hospitalized is also to prevent recurrent stroke, so that we try to figure out why you had a stroke in the first place by imaging, by heart testing, and looking for things like atrial fibrillation and so forth, and to try to administer the appropriate therapy so that we can prevent another stroke. And also things that happen are things to prevent complications of a stroke, things like pneumonia, so we make sure that you're able to swallow appropriately, prevent DVTs, which are blood clot in the legs if you're not able to move very well, prevent ulcer, being stressed in a stressful situation, being sick, and so all of these are very standard treatments that we provide on the neurological service for stroke patients, as well as cholesterol medications, which lowers cholesterol with being a stroke risk factor, but on top of that, it can actually decrease some inflammation, and there's some additional mechanisms that it can help in acute and chronic stroke situations that may be beneficial. And of course, rehab, therapy, and as well as treatment for potential depression and so forth. These are all very important things to maximize function after the stroke and also prevent future problems.
Sure, well, that makes sense. For the type of stroke that's not as common, but the bleed type of stroke, how is that managed? What is that, surgery to stop the bleed, or what does that involve?
So it depends on how big and exactly what kind of bleeding that is, and partially also what is causing it. High blood pressure is also a risk factor for the bleeding type of stroke, and because it causes weakness in the blood vessels, an injury in the blood vessels, and they're more likely to burst as well. So we control blood pressure to decrease the risk of the blood vessel rebleeding. And a lot of people are on blood thinners, and that's potentially one of the factors of causing a bleeding type of stroke. And in those kind of situations, we try to reverse the blood thinners in the blood and try to decrease the likelihood of rebleeding. And in some situations, surgery is appropriate. Some strokes are caused by aneurysm or other kind of blood vessel malformation in the brain. And sometimes surgery or interventional radiologists can go in there and secure the area that's abnormal to prevent rebleeding. And there's also a lot of supportive treatment that we talked about for the blood clot type of stroke as well. That's part of this, things like rehab and prevention of complications and things like that.
Oh, good. What's out there on the horizon in terms of research for stroke or new procedures that are being developed across the country? What are you hearing from your colleagues?
So I think the research, we can think of it in two general categories. So acute treatment, things that are related to TPA and things that we can do when you have a stroke coming into the hospital. So because of the TPA window is about 3 hours, 4.5 hours, 6 hours, in any case fairly short still, there's a lot of people who didn't recognize their stroke or fell out of the window that we can't do anything about from a TPA perspective. So there's a lot of research to try to see if we can evaluate which patients who are safely able to be treated outside of this window. So there are imaging techniques to try to see if we can tell which brain area is already dead and giving the clot busting medication is just going to cause more problems, or which people even at, let's say, 8 hours still have salvageable brain tissue and it's worthwhile to open up the clot. And what is the best procedure to open up the clot? Let's say if you need an intra-arterial, so into the clot kind of procedure, and that's the next level of care that's appropriate in some situations and not appropriate in some situations. So there's a lot of these kind of studies coming out. Neuroprotective agents, things that will decrease the inflammation or the nerve injury after a stroke, those are being actively investigated. So far, disappointingly, we don't have anything that truly is neuroprotective, and that's the holy grail in the pretty difficult thing to obtain. And on the flip side is prevention. We look at socioeconomic factors and public health type of situations and how to best encourage people to have the best lifestyle, the best diet that is helpful in terms of stroke prevention. So I think both from acute treatment and also from a preventative care perspective, there's a lot of research going on.
Well, fascinating. Dr. Wan, we're about out of time. I really appreciate your joining us today and sharing your expertise on stroke. It's amazing what we can do for folks. And I guess if there's two take-home messages, it's the acronym FAST so that people can recognize symptoms and then cut down on our salt intake.
Absolutely.
Two things we could all take to heart.
Yep.
So I'd like to thank our audience for joining us today. This has been presented by Intermountain Medical Center. This will be a monthly offering. Please join us next month when Dr. Clark Cyril, a radiologist, will be speaking on osteoporosis. For now, thanks for joining us on Intermountain Medical Center TV. Good afternoon.